Okay, we are now officially recording, so we are starting Unit 5, Class 3 Zoom session. Let's go ahead and just start off by reviewing the quiz, and then we're going to kind of back up a little bit and finish up respiratory and address any outstanding respiratory type questions, and then we'll move on to cardiovascular, hypertension, and I really want to focus today on both respiratory meds and cardiovascular meds. Because I know that's been an area that a lot of students get frustrated with is medications, pharmacology. So I want to actually go through the meds that were in the class PowerPoints, both of them, and really kind of highlight some important points because I think that will help you. And then I have a surprise for you at the end. So it's all good. All right, so let's go ahead and start with the quiz review. There were 2 true-false questions on there, so let's start with those. And it was arterials are the, I'm sorry, let me replace it. Let me go back here. It was electrodes are placed on the extremities for Holter monitoring. That is false. The Holter monitor is simply a chest leads, and it is attached to a little device that the patient takes with them for about 48 hours just to record their heart rhythm. So there are no electrodes on the extremities. Testing where we do use electrodes on the extremities would be your 12-lead EKG. So that one was false. The next one was AV node is the primary pacemaker of the heart. That also was false because the primary pacemaker is your SA node. Okay, so both of the true falses were false. The last piece was matching, and there were 8 parts to that. So arterioles are the vessels that are most responsible for controlling blood pressure. Lisinopril matched up to can cause significant first dose hypotension, and we'll talk a little bit more about that as we get into the medication part. Angioedema is swelling of the oropharynx, tongue, okay, the throat area. Aldosterone is a substance that causes sodium and water retention. So when we talk about medications, we'll talk about spironolactone being an aldosterone blocker. Reflex tachycardia, that matched up to beta blockers may be given to counteract. But what that refers to, reflex tachycardia is associated with calcium channel blockers. And by lowering the blood pressure, the calcium channel blocker does that, it then causes a tachycardia because the heart feels like it needs to kind of compensate. So with reflex tachycardia, that's why we may give a beta blocker to counteract that effect to help lower that heart rate. Clonidine is a medication that acts in the CNS and it decreases sympathetic outflow. Nifedipine is a calcium channel blocker, so it blocks calcium channels. And losartan is an angiotensin II receptor blocker, and that blocks angiotensin II receptors. So that was today's quiz. All right, so I want to kind of back up a little bit to respiratory. And if anybody has any outstanding respiratory questions, please feel free to put them into the chat box, okay? Otherwise, I'm going to move on. I wanted to kind of follow up on the ABGs that we were talking about. So I'm going to share my screen here, which should take us to the worksheet where the ABGs were. So let me attempt to do this. Okay, share. Okay, so hopefully you're able to see my screen here, and you'll see the steps to interpret the ABG results. Those are there. I'm just going to kind of work my way down, and let's just kind of go through these one by one. Now, again, remember, Unit 5 does focus on respiratory cardiac, so obviously that's our focus for this semester. This worksheet was actually from Foundation, so it does have some metabolic stuff on there, but just to go through the basics of how to interpret these, okay? So if you follow the steps, okay, let's look at the pH of number 1, 7.33, okay? What I would recommend, if you don't already have these numbers in your head, on your paper, brain dump your normal range for pH, 7.35 to 7.45, your normal values for PCO2, which is 35 to 45, and your normal values for bicarb, which is 22 to 26. Okay, so again, looking back at number 1, my pH is 7.33, so that goes towards the acidotic side. My bicarb is 60, okay? So that is going towards the acidotic side, because remember, your CO2 is your acid indicator. So the higher it is, the more acid you have. And then your bicarb, when you look at it, that's going towards the alkaline side. So you're looking for the two that match, and that's your pH and your PCO2. So this is a respiratory acidosis. Now, because your bicarb is moving in the opposite direction, it's going to the alkaline side, okay, I know that there is some compensation taking place. Okay, so there's compensation. However, because the pH is still not within normal limits, it's considered a partial compensation. So this would be a partially compensated respiratory acidosis. Okay, number 2, I'm looking at the pH, 7.47. That falls to the alkaline side, okay, alkalosis. My PCO2 is 42, so that is normal. And my bicarb of 30 is going to the alkaline side. So the two that are going in the same direction are the pH and the bicarb. So that tells me that this is a metabolic alkalosis, okay, a metabolic alkalosis. Because the PCO2 is normal, there is no compensation going on at this point. So it's uncompensated metabolic alkalosis. Number 3, I'm going to skip over because all of the values are normal, so that is a normal ABG. All right. Number 4, pH of 7.21, that is acidotic. Okay, that's acidotic. My PCO2 is 60, so that is also going towards the acidotic side. My bicarb is 24, it's normal. So the two that are going in the same direction are the pH and the PCO2. So this is a respiratory acidosis. And because the bicarb is in normal range, this is considered an uncompensated respiratory acidosis. Moving on to number 5, my pH of 7.48 is alkaline. So we're looking at an alkalosis. My PCO2 is 28, so that is out of whack and it's towards the alkalotic side. My bicarb is 20, which is also out of whack, but that's moving towards the acidic side, okay? So this here is a respiratory alkalosis. Because my bicarb is also abnormal, it's considered a partially compensated respiratory alkalosis. Okay, number 7. Okay, yeah, number 7. Sorry, I'm trying to follow my notes here. I just want to make sure I don't miss anything. Actually, no, number 6. That's why I was getting confused here. All right, number 6, 7.5 of my pH. So that is going towards the alkalotic side, alkalosis. My CO2 is 29, okay? So this is towards the alkalosis side as well. Here, my bicarb is normal, it's 24. So I don't see any type of compensation here. This is a respiratory alkalosis and it is uncompensated, no compensation. Okay, number 7. My pH is 7.28, so that's going towards the acidic side. My PCO2 is 47, okay? So I'm a little bit high there, just a little bit high, but that is going towards the acidic side. My bicarb is 18. This is going towards the same direction, the same direction as my pH. So with this actually, when you look to see, well, they're all going in the same direction. This is kind of messed up. So this is one of those really odd cases. You can tell this is a metabolic problem, mainly because the bicarb is so out of whack and going in the same direction. So this truly is a metabolic acidosis and it has no compensation. So you might see this in a patient who has significant lung problems, or they're just simply, those lungs cannot compensate. Not as common of a situation, but I did want to throw it on there. So if you see something like that out in practice, it's not totally, foreign to you. Number 8, my pH is 4.26. Okay, so that is going towards the alkalotic side. My PCO2 is 26, so that's low. That's also going towards the alkalotic side. My bicarb is 16, so that's low, but that's moving towards the acidotic side. Okay, because remember, your bicarb is your alkaline indicator. So if it's high, I'm more alkaline. If it's low, I'm trying to get rid of that alkaline. I'm holding on to the acid. So number 8 is a respiratory alkalosis, and I know that it's partially compensated because of my bicarb number. Okay, it's trying to compensate. It's just not quite back, doesn't quite have the pH back to normal limits. Okay, number 9, 7.34 for a pH, so I'm on the acidotic side. My PCO2 is 43, so that's looking good. My bicarb is 20, so that's on the acidotic side. So again, the pH and the bicarb are going in the same direction. That makes this a metabolic acidosis. Because the PCO2 is within normal limits, there's no compensation. So if I was to write this out, it's uncompensated metabolic acidosis. I do want to adjust the challenge item here. I put this on because the ones up above all had abnormal pHs, okay? This challenge item has a normal pH, okay? But you need to look farther, because if I look at the PCO2, that certainly is not normal. My bicarb is certainly not normal, okay? So it's not a normal ABG. So when you have something like that, again, start with the pH. 7.41, it is within normal limits, but remember your exact midpoint between 7.35 and 7.45 is 7.4, okay? So am I leaning towards the acidic side, or am I leaning towards the alkalotic side? And 7.41 is falling just slightly alkaline, so we're gonna call it alkaline. When I look at my PCO2 of 59, that's falling towards the acidic side. When I look at my bicarb of 32, that's falling towards the alkaline side. So because my bicarb and my pH are both tilting in the same direction, this is a metabolic alkalosis, okay? It's a metabolic alkalosis. I know that there is compensation taking place because my PCO2 is on the acidic side. It's trying to balance out the scale. So I know it's compensating. I can now say it's fully compensated because my pH is back within those normal limits. Okay, it's back within its normal range. Okay, and that's the difference between partially compensated and fully compensated. If that pH is back in normal range, it's fully compensated. If it's not, but I see that opposite indicator is trying to work to get it there, that's considered a partial compensation. Okay, let me get back to my screen here. Oh, wow. So no questions on ABGs. Nobody's been typing in any questions on ABGs. Okay. All right. Well, at least if you're feeling okay about ABGs, if you could give me a thumbs up in the message box so I know things are going well. Otherwise, if you have more questions about that, do type them in. I will address them. Okay. Otherwise, we are going to move on to looking at the respiratory medications, okay? So it's helpful if you have your PowerPoints, if you printed them out or you have them that you can take some notes on. I just want to highlight some really specific things. Also, maybe I'll just give you my little surprise now. So I spent all morning working on this website. It's really meant for K through 12. But I figured I wanted to give you guys a little, comic relief. But anyway, I created 4 pharmacology review game activity type things. So there will be an announcement up on Plato after the Zoom session today that will tell you how to access them, because I had to do it in a weird way, for it to be free. But I think those will be really helpful for you and help reinforce the meds and the priority points. Okay, so we have a question. So it will always be uncompensated if one of the three numbers are normal. Yes, so if you have a normal number, okay, it's always going to be uncompensated because the other two, the pH and whatever the other indicator is, are likely moving in the same direction, and the other one is normal. So there is an acid-base imbalance, but the body has not begun to compensate, okay? All right, so now I'm going to share a different screen here, and we are going to, oh, hold on a minute. No, I'm not sharing a screen. Hold on, I need to go back here. How about if I share a screen? There we go. I'll figure out this technology yet. It'll be all right. We got this. Okay, so I wanted to first start a little bit with the TB meds. And don't worry, we're going to get through all of them. But I wanted to start with the TB meds because they really weren't on your worksheets. I didn't really hit them, you know, extremely heavily. The big pieces that you need to understand about your TB medications are your patient's going to be on several of them. So multimodal therapy. And the reason we do this is because the bacteria that causes tuberculosis is very, very difficult to eradicate from the body. So you're talking weeks, a lot of times months of therapy. And the reason that they do multiple medications is to make sure they are covering all avenues. What we have seen in the past, I want to say 20 years, 25 years or so, is the development of what we call drug-resistant tuberculosis. And it's happened for a variety of reasons. I mean, you do have bacteria that mutate, but part of the problem is patients were taking medications, but not finishing the entire course. So those bacteria were never fully eradicated. So now, because of that, we are much more vigilant in treating these patients. So they're usually on 2 or 3 different medications in order to treat and eradicate the infection. The other thing that's important is we actually need to verify that the patients are taking these medications. They used to actually have patients come to the health department to get their meds every day so they could take them and we could watch them taking them. Now with today's technology and obviously our social distancing that's going on, that's something we can do via Zoom, via Skype, video conferencing. But it is very important to make sure that the patients are taking the medications as prescribed. They are finishing the complete prescription. Okay, so that's a key piece. The other thing that kind of contributed to patients not being compliant with the TB medication therapy are some of the side effects. Okay, these are not pleasant. These are some pretty heavy duty antibiotics and they're just really nasty. The one thing that you will see in common with all of them is hepatotoxicity. So they can be toxic to the liver. So if you kind of take a step back and think back to unit 4, okay, liver, what's going on with the liver? If the liver is not functioning properly because it's becoming damaged from these medications, your patient's going to have issues with metabolizing waste products in the blood, okay? They're also going to have some problems with perhaps, you know, filtering blood. So things that you would see that you really want to watch for with that hepatotoxicity, certainly we can monitor their lab values and they will do that. They will monitor their lab values, but let's be looking for signs of liver dysfunction. So are they starting to become jaundiced, particularly on the skin and on the eyes? Are they having generalized itching? Because what happens is as waste products build up in the blood and things aren't being detoxified, you will actually get what we call bile salts that kind of deposit in the skin because your body's trying to get rid of them. And those are very itchy for your patient. They might have very dark colored urine, similar to how we talked about with complicated cholecystitis. So looking for dark urine. Those are all things that you want to be watching for because hepatotoxicity is a real risk for these patients. So for your isoniazid, the INH, that's how it's commonly abbreviated. The other big one with this, in addition to the hepatotoxicity, is going to be the peripheral neuropathy. So it's very important that you teach your patients to report if they are experiencing numbness and tingling, particularly of the hands and feet. Now, as we've done research, we've actually found that the peripheral neuropathy is kind of accelerated or made worse if they are deficient in vitamin B6. So if your patient is on this, they are going to be on, some vitamin B6 supplements, okay, to help try to prevent this. But you want to be aware of this, and you want to teach your patient to report this, okay? This is also one that very specifically we give it on an empty stomach. That is because it is best absorbed if it's given on an empty stomach. Now, that being said, if your patient is so nauseous that we are having to choose between them taking it with food or not taking it at all, taking it with food is the lesser of two evils. Okay, that's the lesser of two evils. So again, you know, kind of think about those pieces in relation to your INH. Now, when we move on to the rifampin, again, look at that adverse effect, hepatotoxicity. That is going to be a theme for all of your TB meds. The other big one with rifampin is going to be that it turns urine and secretions orange, or kind of like a reddish orange. And, you know, we talked about, you know, pyridium turning urine orange. This isn't just your urine. This is all of your body's secretion. So if your patient is crying, they're tearing, and they dab their eye, those tears are going to be orange reddish colored. So that is really, really important for your patient to understand. That is very classic specifically for rifampin. The other thing, again, the hepatotoxicity, that's going to apply regardless of what TB medication we're talking about. Okay, so your PZA, again, looking at this, we're looking at hepatotoxicity. So I'm not going to kind of beat a dead horse here. These are all going to cause issues. Our last one, our EMB, this one, you can see hyperuricemia. So in patients with a history of gout, this can kind of aggravate that. This also will cause optic neuritis. So it's very important to watch that visual acuity. And because of that damage, it is not used for kids under like 13. It's just not. But it's really, really important visual wise. We're watching that. It can also cause issues with like color blindness. So again, just monitoring that. But you can see, I mean, these side effects are just really not fun. And with having to take multiple medications, usually several times a day for a long period of time, this is going to lend itself to non-compliance. However, it's that non-compliance that caused the drug-resistant TB that we have. So that's a real big priority. TB is also reportable to the health department. That is tracked, it is reported. When a patient is diagnosed with TB, the health department gets involved and they start trying to trace their contacts to see who they've you know, potentially exposed if they have an active case. And then following up with those people as well for testing, you know, and treatment for them if they were exposed. Okay, just going to check the chat box here. Can TB be cured? You can eradicate the infection if they are taking the antibiotics as prescribed for a long enough period of time. However, that person will always show positive if they're getting TB testing, the MAN2 test, the same ones that you got tested for as part of your clinical requirements. Because when they do your PPD testing and they put a little bit of that protein derivative underneath your skin, what it reacts to is antibodies. Okay, so just because somebody has a positive PPD does not mean they have active tuberculosis. What it means is that one time during their life, they were exposed to TB. So for you to truly tell, does this person have an active TB? We're going to start with the chest x-ray, and the next thing they're going to do is get a sputum specimen and actually be looking for the tuberculosis bacteria. If you test positive for TB on that PPD testing, they won't test you that way again, okay? Once you're positive, you will always show up positive. And what they're really looking for is to rule out that you have any sort of active case. Now, if you have a positive PPD, they will check for an active case. Even if you don't have an active case, they are going to treat you with medication to eradicate that bacteria before it becomes any type of an issue, okay? Because your TB bacteria can lay dormant in the lungs and then resurface later on. We actually started seeing a big resurgence of TB back in the 1980s when we started to see the AIDS epidemic. And that was because with AIDS, it knocked the immune system down, and the immune system was keeping the TB infection in check. But once that was down, that TB was just there and free to replicate and continue on wreaking havoc in that patient. Okay, so I think that covers the stuff on the TB meds that I really wanted to focus on. Let's see here. Okay, all right, so let's move on to the decongestants. And a lot of you are probably familiar with this. You have the phenylephrine. That is the one that's available over the counter, generally without any type of ID. Your true pseudoephedrine, that's the stuff that you have to show your ID at the pharmacy counter, because apparently people can make meth out of it. You know, I don't know. I think those people have way too much time on their hands. But a decongestant is just that. What it's going to try to do is reduce inflammation in the nasal membranes. So if you're delivering this locally through a nasal spray or nasal drops, it kind of stays local. If you're doing PO dosing like your Sudafed, you're going to get that decongestant effect, but you're also going to get a systemic vasoconstriction, which can raise blood pressure. And that's why patients with hypertension are generally advised not to take over-the-counter decongestants, because of that potential rise in blood pressure. Biggest adverse effect of this is your rebound congestion. So it is really important to teach patients, like, look, 3 to 4 days, 5 days max. If you are using the nasal or the topical any longer than that, you're actually going to create a rebound congestion, and you're going to feel worse than you did when you started. So that's really important to teach your patients. Again, for that systemic effect, if you're taking the PO, we do worry about that vasoconstriction, so that can raise blood pressure. Well, it will raise blood pressure, but we get more concerned in patients with pre-existing hypertension or pre-existing coronary artery disease, or they've had a stroke in the past. We also worry about patients with glaucoma, because that raise in pressure is also going to raise eye pressure as well. Okay. The other thing I like to mention, and you see this more with PO dosing, and I have it up there, this agitation, this nervousness, this paranoia. It doesn't affect all patients, but for some that do experience this, it is pretty intense. Now, just because they've experienced it one time doesn't necessarily mean they'll react to it all the time. You know, I look back to my own experience where I had been taking Claritin, which is your basic antihistamine, back when I was in high school, and they switched it to Claritin D, adding that decongestant in there. And let me tell you, I never thought I would be like that, but literally I was nervous. I was walking around like and I worked in a extended care facility. So I thought the people were out to get me. So it was not a good thing. Once I got off that Claritin D back onto the regular Claritin, I was good to go. But some patients may experience that side effect. So just something to kind of keep in mind there. All right, let me just check the chat and see. Okay. All right, so moving on, I think some of you were asking where these slides were from. Some of them were from the pre-class captures, I think from class 1. Some of them are from the class captures from, I believe it's class 1, if you're just looking to reference that. I can also post this specific PowerPoint as well, if that makes it a little bit easier to locate what you're looking for. Okay, so your antitussives, these are all about suppressing cough. Now, sometimes you'll have an antitussive that is combined with an opioid, and that can help with some pain management as well. Because if you have somebody who's persistently coughing, it will actually cause chest discomfort. You can actually, I have had patients that have pulled muscles in their chest from persistent coughing. So that can definitely be a concern. So there's opioid and there's non-opioid. Although the non-opioids too, if taken in high doses, do produce like a euphoria. So there is a potential for abuse there. Again, as we talked about in the last Zoom class, think about when it would be appropriate to use these medications. When would I want to suppress a cough? If your patient has copious secretions, I want them coughing. I want to be able to get that airway clear. Now, if they're hacking and hacking and hacking all the time, we're going to have to find another way to clear the airway, whether it's suctioning, and then maybe give them an antitussive just to let them have some of that rest to kind of regain their strength, regain their breath there. But typically these are used with dry coughs, persistent coughs, like kind of a throat irritation type cough. Relatively safe to use. Again, there is that abuse potential if they're used in high doses. The big thing you want to avoid these in anybody who has been or is taking MAOI antidepressants. And I'm not going to talk a whole lot about MAOIs. You'll talk about those when you get to your mental health course, but that is a class of psychiatric medications that has significant interactions, both with other medications and with different types of food. So that's just something, if you have a patient who is on an MAOI, it's going to interfere with a lot of different things, and you need to be aware of that. So we're trying not to use those as much anymore because of all those interactions. Okay, our expectorants, guaifenesin, Mucinex, Robitussin. I'll tell you what, you talk about those two, those people that market Mucinex, they are brilliant. Those are geniuses. They came up with the little mucus globs on the TV. They're just phenomenal. Great marketing. They deserve a raise. So expectorants will help thin out the mucus secretion a little bit, and it actually stimulates a cough. So it stimulates cough production to expectorate those secretions. Again, it's all about airway clearance. We would use these if your patient has a moist productive cough, or if it's a moist non-productive cough that we want to get things moving, okay? And that's how you would know when you give this and you know it's working, because that moist non-productive cough then becomes productive, that your patient is able to bring that mucus up. For the most part, these are relatively tolerated well. If for some reason it's causing GI upset, give it with food. Otherwise, it really doesn't matter. We do like patients to take these with a full glass of water, for two purposes. One, you want to make sure they get down, start breaking up and getting absorbed. And two, the more hydrated your patient is, the thinner those secretions are going to be. And that's going to make that cough more effective, because when they are coughing, they're actually bringing up those secretions. In some patients, it can cause drowsiness. So obviously, if they're drowsy, they don't want to be doing things that require alertness. That's kind of an across the board thing. If it's causing drowsiness, you just always think about patient safety. Okay. Our mucolytics. So acetylcysteine as a mucolytic, okay, it doesn't stimulate the cough, although when you smell it, it'll probably make you cough and gag. But this is all about thinning and enhancing the flow of respiratory secretions. It's typically given by a nebulizer, inhalation. We have talked about this before in the sense that when it's given in the other forms, it actually counteracts the effects of acetaminophen if somebody would become toxic on that. Not a whole lot of issues with this. It can cause some hepatotoxicity, but again, if you're giving it for acetaminophen overdose, which is worse? If I leave the acetaminophen in there, that's going to kill their liver too. The biggest thing for this is it's given inhalation. It stinks. It smells like rotten eggs. It's kind of nasty. Like I said, it doesn't necessarily stimulate a cough, but your patient will probably want to be coughing and gagging as they're smelling this. But it's all about airway clearance. The more thin we can have those secretions, the more effective their cough can be. We can clear that airway. Okay, antihistamines. And there are two different generations. So our old school antihistamines, your Benadryl, they work really, really well, but they tend to have those sedating effects. They also have the anticholinergic effects. So it causes dry mouth, essentially drying out of all the secretions. So your patient can be uncomfortable with dry mouth. They can have issues with constipation. They can have issues with urinary retention. In cases where patients are taking higher doses, it can actually cause what we call a totally opposite effect. And this also happens where I've heard cases of like parents wanting to like medicate their kids with Benadryl to kind of make them sleepy. I would definitely not do that, because in many cases, children actually have the exact paradoxical effect. They become excited. In some patients and children, this can actually cause hallucinations. It will cause pupil dilation. So if your patient has glaucoma, not such a good thing. It will also cause urinary retention. So if your patient has a history of enlarged prostate or urinary retention, definitely your Benadryl is not a good idea because of those anticholinergic side effects. Now, your second generations, your loratadine, your cetirizine, those are much better tolerated. They're very effective. They don't have those side effects that your traditional Benadryl has. So under the nursing implications, where it talks about avoiding activities that require alertness, that is more referring to the Benadryl. Obviously, anytime you start a new medication, you have to see how your body is going to react to it. But for the most part, your Claritin, your Zyrtec, that is not going to cause issues with sedation and level of consciousness. They're relatively well maintained. You know, they're tolerated, not such a huge deal with that. Okay. Your leukotriene modifiers, these are, I don't want to say new, because now we're talking about, 20, 25 years now, 30 years. But leukotriene modifiers, these are all about actually suppressing certain substances that can stimulate the allergic response. These in particular target leukotrienes, and leukotrienes occur in your body, and they actually cause inflammation, bronchoconstriction, and mucus production. So if we're blocking those, we're trying to reduce those effects. These are used for long-term maintenance therapy. So if you want to think about a priority critical point, these will not treat acute symptoms. And that is really important for you to teach your patient. Okay. If I'm having an acute asthma attack, my Singulair is not going to help me. Okay. So that's a big thing. That's a priority point. The other real big piece that we like to kind of keep in mind, and we see it's more likely to happen in children and teens, but it has happened in some adults as well, is this medication has been found to potentially cause suicidal ideation in patients. So if you have somebody who already has some mental health issues, this may not be a really good choice. Obviously, there's other medications. There's non-pharmacological ways that we can manage symptoms. If we're just talking allergic rhinitis, if we're talking asthma, there may be some different medications that we can use for long-term management. But you always want to be watching for that. Now, if this were to occur, it's most likely going to occur with new dosing. So they're just starting this medication and their body's adjusting to it. If you have somebody who's been on these medications for quite a period of time, this is not really a huge concern, unless they would go off that medication for a while and then come back on it. Okay, our bronchodilators. And with these, a really key point that you need to understand is you have short-acting beta agonists and you have long-acting beta agonists. So you might see them referred to as SABA and LABA. Your short acting are going to be used for acute symptoms, okay? Very, very important, acute symptoms. Your long acting, those are more long-term control, your maintenance medications. So I have some examples up there just for the name. So albuterol, you've probably heard of, you've probably seen it in the hospital. Levalbuterol is a derivative of albuterol, works pretty much the same way. The one difference is that one does not tend to cause the tachycardic side effect the way its brother albuterol does, okay? So sometimes we use that in patients that already have cardiac issues. However, it is very expensive when you're comparing it to straight albuterol, which is why, I don't think it's used as widely as it should be. Now your salmeterol that's up there, that is a long-acting bronchodilator. So that is a medication, and formoterol is kind of a cousin to it. Those are used, long-acting medications that are used in a lot of combination meds that your COPD patients take, where it'll combine a long-acting beta agonist and a corticosteroid, or a long-acting beta agonist and an anticholinergic. But again, those are for maintenance therapy. So just I understand that salmeterol is not going to help with acute symptoms. So getting back to nursing implications, because of the tachycardia I mentioned with albuterol, it's really important that you assess the patient's pulse prior to and after giving albuterol, okay? Whether it's a nebulizer or it's a meter dose inhaler. Okay, if your patient's pulse is already above 100, we get concerned about that. That's definitely something to notify the doctor about. But again, if your patient can't breathe, our first thing is going to be airway and breathing. If their heart rate goes up, the provider may need to prescribe something to help bring that down, to help control that. Okay, so of course, with that, when the pulse rate goes up and cardiac demand goes up, we always worry about the patient not having enough oxygen to the heart muscle. So certainly if they start developing chest pain, jaw pain, arm pain, anything that might indicate a heart attack or ischemia to the heart, that needs to be immediately reported. The other thing that's important with these medications, particularly the short acting, when you have a respiratory patient that is on multiple respiratory meds, you want to give the short-acting beta agonist first, okay? Because when that gets in there, it helps open up the airways. I can get other medications down farther. So you always want to give your short-acting bronchodilator first. You should wait at least 10 minutes in between different types of medications. If you're using an MDI, a meter dose inhaler, and it's the same medication, they're taking maybe 2 puffs of it, you really should wait 1 to 2 minutes in between those puffs. And then in between the different medications, you really should be waiting 10 minutes. I think that kind of hits the big pieces of that. Your corticosteroids, and I'm actually going to hit various ones here because corticosteroids, depending on why your patient's taking them, they can be given nasally, okay? They can be given via inhaler, so MDI, DPI, nebulizer, and then they can also be given PO or IV. So I want to kind of get into that a little bit. All right, let me just take the check. Okay, I'm just checking in on the chat just to make sure I'm hitting what you need to hit. So getting back to the corticosteroids, let's talk about let's talk about nasal first, okay? So remember I was mentioning before the decongestants, okay? So kind of in the same way, you can have inhaled or nasal corticosteroids that are very localized to the nose. Typically these are nose drops or they're a spray, like your Flonase nasal spray to help reduce the edema in the nose. Those are typically used for like allergic rhinitis, some sinusitis, things like that to help open up the nasal passages, okay? So with those, it's very localized. You generally don't get effects beyond that specific area. Now, with your inhaled ones, okay, your inhaled, whether it's a meter dose inhaler, a DPI, a dry powder inhaler, or an actual nebulizer, These are for prevention and maintenance, okay, of COPD asthma symptoms. So this is that long-term maintenance therapy. Now, that being said, there's some things you need to keep in mind with this. Anytime you're taking a corticosteroid in inhalation, they need to rinse their mouth out afterwards. While it's best practice to do that with all inhalers, it is most important to do it with the corticosteroids, because if you don't, they can actually change the normal flora in the mouth, and it can actually result in thrush, the development of a yeast infection in the mouth, that candidiasis. So rinsing that after any type of inhalation is going to be very, very important. Of course, when you're looking at the oral cavity, you want to be watching that oral assessment. Are they developing any sores? Are they developing thrush? You know, that's a concern. Long-term inhaled steroids do put the patient at risk for osteoporosis. We talked about that in Unit 3, long-term use of steroids. It is going to affect bone deposits, you know, in your bones, the calcium deposits in your bones. So again, you know, the lesser of two evils. If your patient does need to be on an inhaled corticosteroid, this is part of their maintenance therapy. We need to be doing dietary teaching to increase calcium, increase vitamin D. They may also need to be on calcium and vitamin D supplements as well. Now, for the IV and the PO, okay, these are used short-term for exacerbations, okay, for an acute asthma flare-up, for a very acute episode of COPD, okay? This is all about suppressing inflammation, suppressing airway mucus production, okay? So if we have to kind of get them over that hump of the exacerbation, we're going to use things like IV methylprednisolone. That's kind of the first thing that we'll give. That can also be given IM, although if the patient's going to be hospitalized as an inpatient, we're going to give it IV. However, sometimes if the patient is seen in urgent care or in the ER, they may give it via IM injection and then give them a prescription for PO prednisone, okay, to kind of taper that dosing. The reason we taper the dosing is because your body makes natural glucocorticoids. They're in the adrenal glands, but your adrenal glands can get lazy. So if your patient's been receiving high doses of IV or PO steroids for several days, they kind of start slacking off because those medications that we're giving are basically doing the work of the adrenals. Okay, so that's why we taper the dosing. We don't ever stop it abruptly. Okay, now with those exacerbations, with that short-term use, one of your priority side effects is going to be hyperglycemia. This is going to shoot their blood sugars up. This is even in a non-diabetic patient. Okay, a non-diabetic patient, it is not uncommon for them to run in the low 200s if they're on IV methylprednisolone or they're on PO prednisone. Okay. Your diabetic patients, it's going to shoot them up even higher. So we get very concerned about the development of your DKA or your HHNKS. So it is very, very important if your patient, particularly IV corticosteroids, that these patients are prescribed finger stick blood glucose checks, and they're typically on sliding scale coverage, okay, depending on what that value is. Do keep in mind we use rapid acting insulin and regular insulin. Most of the time it's rapid acting insulin. As coverage for sliding scale coverage, that's the type of insulins that we use. Your diabetics may require increased insulin. Well, not may, they will. Diabetic patients that are generally controlled with just PO medications or your non-insulin injectables, they are likely going to require insulin temporarily while they are on that IV medication. Okay. When they transition over to the PO dosing, prednisone, corticosteroids, they're part of that Fab4 that we talked about with gastritis. So you absolutely must administer these with meals. Okay. I don't know why they have not invented an enteric-coated prednisone. I have no idea. That's kind of beyond my scope of practice, but if they ever did, oh my gosh, they would be millionaires, because that would really be a need. As soon as you put the prednisone in your mouth and you start drinking, it starts dissolving. It's nasty. You want to get it down as quickly as possible, but they need to give it with food, or else it definitely is going to cause gastritis, maybe even potentially gastric bleeding. Okay, so your anticholinergics, and in this case, I'm talking about the inhaled anticholinergics, your ipratropium. You've probably heard of that. If you've taken care of a patient who's received a duo neb in the hospital, it is a nebulizer that includes albuterol and ipratropium. Now, the tiotropium or the Spiriva, that is an even longer, long-acting medication. So your Spiriva is typically going to be your, that's the one that comes in a capsule, and you put it in the little adapter, you crush it. It was a powder inside the capsule, and then they inhale the powder. So again, this is long-term maintenance management of COPD and asthma. That's typically what we're using that for. Again, relatively well tolerated. It is going to cause the anticholinergic side effects. You're going to get that dry mouth. So it's important for them to drink lots of fluids. They might suck on some sugar-free hard candy just to kind of keep that mouth moist. Anybody who gets repeated respiratory medications can develop some throat irritation, so it can change their voice a little bit. You know, again, just make sure you're spacing out your respiratory medications. Looks like when I made this slide, the reference was talking at least 5 minutes in between administration of multiple meds. Generally, your resources are going to say anywhere from 5 to 10 minutes, but you're always going to give that short-acting bronchodilator first. That's a really important point if your patient is on multiple medications. Okay, so I'm going to just stop here just for a second. I'm going to check the chat box. This kind of wraps up our respiratory piece. So if anybody has any respiratory related questions, now would be the time to put them in the chat box. I'm going to check the chat box here. Yep, okay, so typically I just want to address this again. 5 minutes between different meds, 5 to 10 depending on what your resource is. 10 is best, at least 5. And really it should be, the best practice is 1 to 2 minutes between puffs. At least 60 seconds is kind of the goal. So that's really a patient teaching point for when you're educating these patients on how to take them, these medications at home. But also for you as you're practicing, you know, with taking care of your patients. All right. So I don't see any more respiratory questions at this point. So I'm going to kind of just move on. I want to hit some key pieces on the cardiovascular diagnostic testing, particularly related to the cardiac stress test. Thank you to those of you who did the worksheet related to this class. I've already seen what you put up. I've given you some feedback with this. With the cardiac stress test, whether it's the exercise one or the pharmacologic one, there's some important things that you need to know about pre and during, well, and post-test. But really prior to this, this is considered a higher, I don't want to say high risk procedure, but it definitely carries some risk. So there is an informed consent for cardiac stress testing. So as a nurse, you would be responsible for witnessing that consent. These patients need to be avoiding caffeine, generally for at least 48 hours beforehand. Depending on the provider, some of them actually tell them not to take their cardiac meds the morning of the test. Some of them do. That's going to be very specific to the provider that will be reading the test. As they are doing these tests, whether it's exercise or we're exercising the heart because of a medication, we're always looking to see how they are tolerating this test. So are they experiencing any dizziness? Are they experiencing any palpitations, any chest pain, any chest pressure? If that's happening, you need to stop the test. Okay, that's really, really important. We need to stop that test, get your vital signs, look at that EKG tracing, notify the provider. You might need to put oxygen on them if they're SATs down. Again, that's a really important point. Afterwards, there's not a whole lot of issue. They're going to follow up with the provider. They're going to read the results and see. But If your patient experiences distress during the test, ischemia during the test, you need to immediately stop that. Okay, so then we can proceed from there. With angiography, again, angiography requires IV contrast. So going back to the basics, what are your patient's allergies? Are they allergic to contrast dye? Are they allergic to iodine, shellfish? You always want to know that. You want to know what your patient's kidney status is. What is their BUN creatinine? What is their GFR? Okay. You also need to know if they're getting a cardiac cath, anything using IV contrast, if they're on metformin. If this is a planned cardiac cath where I know it's scheduled, I'm going in 4 days for a cardiac cath, they will have them hold their morning dose of metformin. If it's unscheduled, which a lot of them are, if your patient comes to the ER reporting chest pain, they're going to go to the cath lab and, you can't reach down their throat and pull that metformin back out. If it's unscheduled, whether it's scheduled or unscheduled, we are always holding that metformin a minimum of 48 hours afterwards. Basically, if there's a concern about kidney function after that 48-hour period, they're going to resume the metformin based upon lab results. So they'll repeat that BUN, creatinine, GFR, and see where we're at. The other piece that I'd like to mention with the angiography is when your patient comes back post-procedure, okay? Now, remember how they do this test. They're going to thread the device up through a vessel. A lot of times they'll use the upper extremities, so maybe they're going in through the brachial artery. A lot of times they might use the groin. They might have gone in through the femoral artery. In some cases, they may prep different areas because they may find that they need to change their insertion, change their approach during the test. Regardless of what they use, you always need to watch that insertion site or sites for bleeding. You're also looking for formation of a hematoma, which is bleeding underneath the skin, that would start causing discoloration. The skin would become edematous. You can actually feel like a hard ball if there's a hematoma. You're also concerned with circulation distal to the insertion site. Okay, so if you go back to Unit 3 and we talked about neurovascular checks, those are going to apply to your cardiac cath as well. Okay, so if they went up through the right groin, you need to make sure you're assessing your pulses, your posterior tibial, your pedal pulses, your capillary refill, the temperature of that extremity, the color of that extremity, okay, and comparing it to the unaffected side. Again, if they went in through two different approaches, if they went in through the right brachial and the right groin, you're having to assess both of those, and you're always comparing to the opposite extremity as well. Okay, very, very important. The other piece with the angiography is that your patient is going to need to keep the extremity straight and still for a period of time. How long depends on the approach that they use. It depends on the sheath that they use, what type of closure device they've used. So that is going to be in your post-procedure orders, but there will be a period of time that your patient needs to keep that extremity straight and not moving around. Okay, so we may need to help them with that. They're not going to be able, if it's a groin approach, they're not going to be able to get up and go to the bathroom. So they may be using a bedpan, urinal, that sort of thing. You know, we're not having them up and moving around. Okay, so those were the big points I really wanted to cover with that. Echocardiogram, if it's the transthoracic, it's just the basic ultrasound of the heart. If it's the transesophageal echocardiogram, if you kind of think about this in relation to like a bronchoscopy or an EGD, basically they're inserting the probe down the throat, down in the esophagus, and then they're taking pictures of the heart. So anytime you're doing a type of procedure like that, we have to numb the gag reflex. So all the same things that applied for the bronchoscopy, after your patient has a TEE or a bronch, your priority action is going to be watching that gag reflex. They can't eat or drink anything until that gag reflex returns. So I think that kind of covers what I was looking to hit there. As we're going through here, of course, if you have questions, please go ahead and pose them on the chat box. Otherwise, I'm going to move into hypertension here because I do want to hit the hypertensive meds. Just some basic concepts, and you can go back and listen to the pre-class capture. But when we talk about hypertension, this is all going to relate to cardiac output. Okay, how much blood is the heart pumping, and what is the resistance it's pumping against? And when we talk about a patient having decreased cardiac output, that's a problem, because if the heart's not pumping effectively, it's not delivering the oxygen and glucose to the cells that they need to make ATP. So it's a big issue. Stroke volume just refers to the amount of blood that gets ejected from the left ventricle. Well, from any ventricle, but we really focus on the left ventricle. Normal is anywhere from 60 to 120. And how much the stroke volume is going to be is going to depend on a lot of things. If your patient is in fluid overload, so I have an increased preload, that stroke volume might be diminished just because of the amount that they're having to try to push at one time. If they're dehydrated, I have a low preload. Obviously, if I have less fluid in the system, it's not going to be, ejecting as much. Afterload becomes an issue because that's the pressure that it has to push against, that ventricle has to pump against. And that's really the main issue with hypertension and how it leads to heart failure, is because your ventricles have had to work harder and harder to pump the blood against that pressure, against that systemic pressure. And that's why uncontrolled hypertension leads to heart failure, just simply because of that. And, if the heart's not beating effectively, if it's not contracting effectively, you have all this extra pressure on it, it's just not going to effectively pump out that blood. Okay, this is just a repeat of the visual that was in the pre-class PowerPoint, just to kind of show you. Preload is what's coming into the ventricles at the end of diastole, and it shows it on the right side of the heart, but the truth is preload also affects the left ventricle. So when you have a patient with something like atrial fibrillation, where the atria are quivering instead of that nice contraction, that last atrial kick to push that blood, the remainder of that blood down into the ventricle, that just means there's going to be less blood in the ventricle to begin with when the valve closes and then the other one opens to pump out. So preload is definitely a factor there. Afterload, as I mentioned before, that's the resistance, that's the pressure that ventricle has to overcome to circulate the blood. So those are just some real basic concepts that you want to be aware of. So hopefully you took a look at the article that's posted on Plato. It's called Hypertension, the Pressure's On. It is a really, really good article. I don't generally post a lot of extra things for you to read. This is one that I would recommend printing out and actually keeping. You'll refer to this in MedSurg 2, you'll refer to this MedSurg 3, you'll even refer to this in OB when you talk about pregnancy-induced hypertension, because all of this talks about the regulation of blood pressure, how your renin, angiotensin, aldosterone system works. And what's really cool is if you take a look at this diagram, as we get to the medications and we talk about the different classes and how they work, a lot of them you can see how they are working in this RAAS system. And if you understand where they're working, it makes sense why you see the side effects that you see. Okay, so please take a look at that article if you have not done so already. It's definitely a keeper. All right, so let's get into the medications. And I understand you've gone over diuretics as part of foundations with fluid and electrolyte acid-base balance, okay? For the purpose of what we're talking about with diuretics, we are talking about reducing some excess fluid in the body, mainly to lower the blood pressure, okay? So we're reducing the amount of circulating volume, so we're kind of, not overfilling the pipes, so to speak. While loop diuretics can also be given for heart failure for fluid overload, that's not going to be our focus at this point. Here we're looking at increasing urinary output, we're reducing the amount of circulating volume, we're reducing the amount of preload, okay? for the heart to pump more effectively, and for the pressure to be down. So when you talk about loop diuretics, they're going to make your patient pee. That's what they do. They help them get rid of excess fluid through urination. Now, they're also going to be losing potassium, and with loop diuretics, that's a concern because they have that potential risk for hypokalemia. Okay? So when we talk about loop diuretics, we're talking about them in relation specifically to hypertension. So we want to know what that serum potassium level is. Now, certainly if we're giving something IV, that potassium level is going to drop much more quickly. If we're giving it PO, we can usually manage that potassium loss with diet modifications. So somebody on a loop diuretic, they need to know foods that are high in potassium because we want them to consume those foods, okay? Obviously, we're giving this to lower blood pressure, so you want to make sure you're assessing blood pressure before you give the medication, okay? We do watch intake and output and daily weight. However, that is going to relate specifically to heart failure as opposed to hypertension. Most patients who are solely being treated for hypertension are not taught to weigh themselves daily. If they also have heart failure, that's why they're weighing themselves daily to monitor that overall fluid status. From a safety perspective, we're worried about orthostatic hypotension, so they should be taught to change positions slowly. And loop diuretics can influence glucose levels. It might cause a little bit of hyperglycemia. You know, so that's just something to kind of keep in mind. If it's a diabetic patient, they should be checking their sugar. Thiazide diuretics pretty much work the same way as loop diuretics. It's just in a different section of the loop of Henle. What's nice about thiazide diuretics is they also are potassium depleting, but they are not as potassium depleting as loop diuretics. So a lot of times, if your patient's on hydrochlorothiazide, if they're on combination therapy, they might put them on hydrochlorothiazide and lisinopril, and that will nicely balance out that potassium loss because the lisinopril holds on to potassium. Okay, so your thiazides are very much like your loop diuretics. Same type of thing, they can cause that increased glucose level. I do want to make sure that I am assessing blood pressure before we give it. I do want to make sure I'm cautioning my patient to change position slowly. Okay, let me just double check the chat. I see something's popped up here. Orthostatic and postural hypotension, the same thing. Yes, they are. You know, nursing, we have 17 words for the same thing. So yeah, orthostatic hypotension, you know, when you're changing positions and it drops, and postural hypertension refers to when you're changing posture, when you're changing position. So they are exactly the same thing. Good question. All right. The other diuretic that we have, it's considered a potassium sparing diuretic, is spironolactone. However, in addition to being a potassium sparing diuretic, it works by blocking aldosterone. Okay, so it's also considered an aldosterone blocker. So it's kind of hitting it in two different ways. Okay, so this is also used obviously to treat hypertension. It's used to treat other things as well. But again, we're focusing on the hypertension. In this case, it's going to hold on to potassium. So just like my other two types of diuretics, I want to teach my patients about foods that are high in potassium. But in this case, they either need to avoid or try to minimize those things because I don't want them to become toxic. I don't want them to become hyperkalemic. Okay, so very important. I do want to mention that salt substitutes, okay, because it's hypertension. We want to avoid salt. They want to be on a sodium restricted diet because that's going to help lower blood pressure. Well, why not use a salt substitute? When they take the sodium out, they replace it with something. Most of your salt substitutes, the replacement is potassium. So that's very important for you to know. It's very important for you to teach your patient as well. Okay, they need to be avoiding salt substitutes because of the potassium that's in them. Otherwise, they're very similar to diuretics. It's going to make your patient pee a little bit more. But again, the big key piece is going to be that potassium. Okay. Why do these diuretics cause hyperglycemia? Very good question. When they are working in the kidney and it promotes, well, it basically causes the kidney to put out more fluid, more urine, sodium, and for your potassium depletings, it also puts out the potassium. However, it causes you to kind of hold on to some of that glucose, and that's why you can see an increase. Now, in most patients, it's not a significant increase. Like, it's not going to take somebody who's relatively controlled and shoot them up into the 200s, 300s. It's usually not a big issue unless you have somebody who has uncontrolled diabetes. But very good question. Okay, so you heard me mention before, diuretics, they're all about the K. It's like that song, all about the base, all about the K, about the K. Okay, so as a nurse, you need to know with the diuretics that your patient's on, are they at risk for hypokalemia? Are they at risk for hyperkalemia? Regardless, it's not a good thing. Okay, if the potassium's too low, it's bad. If it's too high, it's bad. So regardless of what your patient is on, they need to know foods that are high in potassium. If they're on a potassium depleting diuretic, they want to eat these foods. They want to eat them and replace that potassium. If they're on spironolactone, which is potassium sparing, or they're on things like ACE inhibitors and ARBs, which we'll talk about in a minute, those things hold on to potassium. So they would want to limit these foods so they don't become hyperkalemic. Speaking of ACE inhibitors, and you'll see what they have in common, they're prils. Okay, they're prils. So these are all about inhibiting the conversion of angiotensin 1 to angiotensin 2. Okay, well, that's great. What does that mean? What you need to understand is angiotensin 2 causes vasoconstriction. If the vessels are constricted, the pressure's going up. Okay, so if I'm blocking that, if I'm kind of avoiding as much angiotensin 2, my vessels are going to stay more relaxed. Okay, these also stimulate the retention of potassium. So as I mentioned before, with your potassium sparing diuretic, your aldactone, your spironolactone, you can become hyperkalemic. The same is true with your ACE inhibitors, so they need to watch for that. Adverse effects, the very first thing that is mentioned there, and it has an exclamation point. Highlight it, circle it. It is so important. First dose hypotension, okay? These medications, because of how they work, that very first dose that your patient takes, they are at significant risk for a rapid drop in blood pressure. So they need to be kind of taught after they take that first dose, they really need to kind of stay seated. They need to stay flat for at least 2 hours so their body starts adjusting to this. They are at major risk for further orthostatic hypotension, falls, injury. So that's really, really important. Another big adverse effect is going to be that dry, persistent cough. It's very common if patients experience this and it becomes really interfering with their quality of life, they'll often switch their medication to something else. The other big, big adverse effect that you need to be watching for, and again, this typically happens with new dosing or changes in dosing, maybe we're adjusting the dose up, is angioedema, which is the swelling of the tongue, the oral pharynx, and basically that can completely occlude your airway, and now it's almost similar to an anaphylactic shock. I've seen different levels of angioedema. It can actually progress up into the face, the bottom part of the face, and up towards the eye as well. It's pretty serious, so you need to be watching for that. Everything that's there under nursing implications is stuff that we've talked about before. All about the potassium, all about the drop in blood pressure, keeping your patients safe. Your ARBs or angiotensin 2 receptor blockers. So if you kind of think about how these work in relation to the ACE inhibitors were blocking the conversion, okay? Here the conversion has taken place. I have angiotensin 2, but now this medication blocks the receptors for the angiotensin 2 for it to work on the vessels, okay? These tend to be tolerated a little bit better than your ACE inhibitors. You don't tend to see that dry, hacky cough. So sometimes if they can't tolerate like lisinopril, they'll switch them over to an ARB and see how they do. Okay. Again, adverse effects. I'm still worried about that angioedema. I'm still watching for that. I'm worried about my potassium levels. So all that potassium teaching is going to apply. And again, hypotension. So again, not very different than your ACE inhibitors. They really work very similar, just at slightly different parts on the path. Your beta blockers, okay? And there are selective and non-selective beta blockers. So you'll see the first row that I have up there just as BBs. Those are your selective ones that they work specifically on the heart, or they affect just the heart. Your non-selectives, your alpha and your betas, okay? Those can affect the lungs as well. So your alpha and beta blockers, your carvedilol and your labetalol, those are ones that you would not want to use in a patient who also has respiratory disease, COPD, asthma, anything like that. Your regular betas, your selective betas, your atenolol, your metoprolol, those are fine to use. But it's the non-selective ones that can be dangerous for your respiratory patients. So adverse effects of this is going to cause a drop in your patient's heart rate, okay? So as the nurse treating an inpatient client, you want to assess their apical heart rate for a full minute, count it before you give this medication. Now, patients take PO beta blockers at home all the time. They are not checking their apical heart rate, but we should be teaching them how to palpate their radial pulse and how to count their radial pulse. And they should be doing that before they take the medication. I have on the screen hold if it's less than 50 or otherwise specified. That's really going to depend on your patient's parameters. So for example, some patients it'll be less than 60, it'll be less than 55. In general, the textbooks will say less than 50, some say less than 60. I kind of use less than 60 as a rule of thumb. If I get a heart rate less than 60 and there's no parameters specified, I'm going to hold the medication temporarily while I contact the provider for additional instruction. Another thing that is absolutely huge, and we talked about this in Unit 4, your beta blockers will mask the typical signs and symptoms of hypoglycemia. So your patient's not going to get those, cold and clammy and the nervousness and the tremors that you typically would see with hypoglycemia. These patients can literally be talking to you 1 minute and be out and unconscious the next minute. So it's very important that your patients who are diabetic are watching their blood glucose levels, especially if they are prone to hypoglycemic episodes. PO doses should be given with food. Again, we want to change positions slowly with these, okay? It can cause orthostatic hypotension. And again, as I mentioned before, the bronchoconstriction specifically with your non-selective ones, your carvedilol and your labetalol. I'm watching the chat box. I don't see a whole lot of questions, so I'm hoping I'm hitting what you need here. Moving on to calcium channel blockers, nifedipine, amlodipine. Those are your kind of classics. You do have the odd one out, the verapamil. But these are all about blocking the calcium channels in the blood vessels, and basically that causes vasodilation. It also slows the rate of conduction through the AV node, so you'll see calcium channel blockers like diltiazem are often used for patients with AFib. Now, again, for what we're talking about hypertension. So what you're typically going to see used is your nifedipine and your amlodipine. Those are probably the two most common calcium channel blockers used for hypertension. As I mentioned before, as part of the quiz, as an adverse effects, these will often cause reflex tachycardia. So as we lower the blood pressure, it can then speed up the heart rate. So they may use a beta blocker to counteract this. Again, you want to change position slowly. You can have that orthostatic hypotension. If your patient overdoses or becomes toxic on it, which to be honest with you is very rare with PO dosing, that's typically not going to happen unless you're talking IV. Again, we worry about dropping the heart rate too low, and then at that point they may require pacing. Again, with hypertension treatment, that's not as big of a concern. You'll talk more about that next semester when you get into cardiac dysrhythmias. Your centrally acting alpha-2 agonist, most common one seen is clonidine. This one basically is going to decrease sympathetic response in the CNS. It will cause vasodilation. It will lower the heart rate. PO dosing, we use this kind of like as a PRN. If their systolic pressure is above 60, we typically give the clonidine. It can be given as a transdermal patch for a very slow dosing, and it does work really well. Again, just your typical things, changing position slowly. This isn't one you're going to see routinely used as much as the other ones. Your vasodilators, your hydralazine, nitroglycerin is up there as well. That does cause vasodilation, but with your nitro, we specifically use that for vasodilation of the coronary arteries. So you'll talk much more about that next semester, but it is technically classified as a vasodilator. I wanted you to be aware of that. But for hypertension treatment, we're typically not using nitro. Hydralazine does promote systemic vasodilation, and it can be given PO or IV. This is typically used as like a PRN medication, particularly the IV hydralazine. That if their systolic pressure is above like 160, 180, they'll give that dose of hydralazine. Again, it's going to lower your patient's blood pressure. You always want to know what their pressure is before you give any of these medications. You know it's going to drop it. That orthostatic postural hypotension is going to be a concern. Your alpha-1 blockers, these are a newer class of medication, not always routinely used for hypertension. Usually we get to these if the other things aren't really working. If your patient has hypertension and also has BPH, you can kind of kill two birds with one stone here because it is helpful with that. From a vessel perspective, it causes arterial and venous dilation. Again, if I'm relaxing the blood vessels, that's going to decrease the blood pressure. This one, just like your ACE inhibitors, has a very significant first dose orthostatic hypotension. So that's pretty important. Your patient needs to know that. This medication, you can see that effect up to 6 hours after that first dosing. With the regular ACE inhibitor, usually we talk about lisinopril. If you're going to see it, you're going to see it in the first 2 hours with the lisinopril. With your alpha-1 blockers, you can actually see it up to 6 hours. So you really want to monitor that patient very closely. Because of that, these effects, it's often recommended that the patient take this at bedtime, so they're already lying down when this vasodilation occurs and the drop in the blood pressure, and they're less likely to be up and moving around. Okay, let me stop sharing my screen now and I'll get back to the main thing. All right, so wow, that's a long one. I didn't realize we went this long. We're almost at 2 o'clock. Well, that's all right. That's good too. Let me just look at my notes here. If you have any other questions, oh good, we're getting some questions here. If you have questions, go ahead and put those in and I will address them. Otherwise, the other thing I wanted you to know, I mentioned before, I did create some pharmacology games to kind of help you review the pharm content. And I had to post them to a Google Classroom. It was the only way I could do it for free without having to pay for some subscription. So there will be an announcement on Plato that tells you how to get to that. I am not using that Google Classroom for anything else. It is just for games. I'm not going to be posting announcements. I'm not communicating with students on the Google Classroom. It's just for games. Okay. All right. So Coming down the questions, what can wide or narrow pulse pressure cause? Are there any causes of these? So when we talk about pulse pressure, that is the difference between systolic and diastolic readings. And it, you know, it's kind of like, we'll talk a little bit more about it when we get to neuro. But the reality is, if you have too wide of a pulse pressure, if you have too narrow of a pulse pressure, it affects overall circulation and cardiac output, and essentially getting the oxygen to the tissues. So when we look at that, if you're having a narrowed pulse pressure, that can indicate that you're starting to go into cardiac failure as well. What medications are used for a pharmacologic stress test? Are there any nursing interventions considerations that are different for pharmacologic stress tests related to the meds? No. You're basically, what the medications that we're going to give in a pharmacologic stress test, they're basically just going to tax your heart the same way activity and exercise would. So they're going to increase your heart rate, kind of stimulate it, contracting a little bit more, going at a higher rate. So there's no consideration specifically for that, because what we want to stimulate an exercise response. Okay. So our biggest issue is if your patient starts developing symptoms in a cardiac stress test, dizziness, the palpitations, the chest pain, the chest pressure, they need to stop the testing right away. We don't want to continue with any more medication. We also don't want to continue with them, doing any type of additional exertion that is going to put further strain on the heart. Okay, let's see. Can you go over the lab tests, CRP and homocysteine? Yes, I mentioned those in the pre-class PowerPoint because they were in your reading. With the CRP and the homocysteine, those look at some different inflammatory factors, and they are associated with an increased risk of heart disease, coronary artery disease. So you'll hit them much more next semester. I just wanted you to be aware of them. As you know, they might be elevated in a patient that has some hypertension, because hypertension is a risk factor for coronary artery disease. But those things are usually used to assess a patient's cardiac risk. When would you use the 12-lead ECG versus continuous monitoring versus Holter versus transit wireless monitoring? Okay, so the 12-lead EKG is the most effective in looking at your patient's cardiac electrical activity right now. It's 12 leads, so it looks at the electrical activity from different angles. So if your patient is experiencing chest pain, that's one of the first things we're going to do, is take a look at that 12-lead EKG. Continuous monitoring is used typically for your inpatients. So they're admitted to the hospital unit and they're admitted with telemetry monitoring. So usually it's going to be either a 3-lead or a 5-lead, but it provides a continuous tracing of your patient's heart rhythm. Those are generally set up on the monitors in the inpatient facility, and there are certain things that are going to trigger an alarm. Certainly if their heart rate goes too low or goes too high, if there is changes in the electrical activity, how long it takes to conduct through the P wave and the QRS complex and the T wave. And if that sounds a little advanced, don't sweat it right now, okay? That's just the things that those monitors will pick up. So if your patient is admitted as an inpatient, certainly for any type of cardiac event, but also if they're admitted for a med-surg reason, but they have a significant cardiac history, they might be ordered continuous monitoring. The Holter monitor is an outpatient monitor. That is something that your patient typically wears 48 to 72 hours. There's some leads attached to their chest. It's hooked up to this little device, and it's basically monitoring their heart rhythm during that time. And the patients are taught to keep a diary of symptoms, or sometimes there's a button on the side of it that you push the button if you start having symptoms, because it marks it on the recording. And then after the Holter monitoring is finished and they go back and essentially read the rhythm, they're looking to see an association of the symptoms with any type of activity or events, trying to figure out what's going on. It's more of a diagnostic thing. The wireless monitoring with cardiac rhythms and stuff like that, that also relates to pacemakers as well, where they are basically monitoring from a distance. Even in your clinical units, particularly those of you that are at Jersey Shore know this as well. If your patients are out on the regular inpatient unit, those are the portable cardiac monitors. They're attached to their chest and connected to a box, and the box goes with the patient. They're not hardwired to the monitoring equipment. Whereas over in an ICU setting or the CCU setting, they're actually hardwired to the equipment there. So that's what that's referring to. How do they determine which one they are going to use, pharmacology or exercise for a stress test? Great question. So exercise is best. However, if you have a patient who just simply can't walk, it can be a physical issue that they can't walk. Maybe they also have peripheral arterial disease. Maybe they have an amputation. Maybe they are just so debilitated that that's just not an option. Then we would choose the pharmacologic stress test. Again, which one they would do is going to be up to the cardiologist. It's going to be up to the provider. So as the nurse, you need to be prepared for both. However, regardless of which one we use, both of them require the informed consent. Both of them are going to have the same things that we're watching for during the actual test. Okay. If they start developing that dizziness, that chest pain, chest pressure, palpitations, we need to cease the test, regardless of if it's pharm or exercise. What is CK? CK-MB is a cardiac biomarker. So CK is creatinine kinase, and CK-MB is creatinine kinase. I think it's myoglobin or something to that effect. What happens is CK is an enzyme that gets released when there is muscle damage. Okay, but CK is not specific to the heart. If you think back, you have skeletal muscle, you have cardiac muscle, you have smooth muscle. So CK is going to be elevated if there's any type of muscle damage. So if you have a patient that's in a significant trauma, a fall, a motor vehicle accident, their CK is going to go up. CK-MB is cardiac specific. So they may have an elevated CK level, but when we check the CK-MB, it's fine. So the trauma to the muscle was not cardiac related. It may have been skeletal. And that's all of the questions I have for now. Any other last minute questions? Well, I don't see any more. I think this was a very productive session. Hopefully you found it productive in going over the medications. Do watch for that Play-Doh announcement to the links to the cool games that I created for you. I think you'll like them. Hopefully they'll be helpful. And I will see you guys on Friday then. Please feel free to email, contact me with any questions. Take care. Have a great day.